Hello, everybody. My name is Neil Johnson from Auckland, New Zealand, and it is my very great pleasure to introduce this ED talk on how has our understanding of endometriosis changed in the last decade. And it's my really great pleasure to introduce my dear friend and colleague, Professor Yutaka Osuga. Hello, Yutaka.
Hi, hello everybody.
Yeah, so Yutaka is Professor Emeritus at the University of Tokyo. He is the Director and Professor of the Teikyo Academic Research Center, Teikyo University in Tokyo. He is also currently the President of the Japan Society of Fertilization and Implantation and the immediate past President of the Japan Society for Reproductive Medicine and the Japan Society of Obstetric and Obstetric Endoscopy, gynecologic endoscopy, and minimally invasive therapy. Not only that, but he is now on the Aspire Executive Board, having been a deputy editor for Fertility and Reproduction, FNR, the Aspire Journal, and a previous chairperson of the Aspire Special Interest Group in endometriosis. So I think, Yutaka, you are very well qualified to talk to us about how endometriosis and our understanding of it has changed in the last decade. And I think that this will be a very interesting Ed talk. We look forward to learning a lot from you. So if you were to, say, pick three key areas where you feel that our understanding of endometriosis has changed in the last decade, what would they be?
So the first one is endometriosis is not only the cause of pain and infertility, but also of multiple conditions. The second point is the shift to early diagnosis and long-term medical treatment pro-surgery, so surgery-oriented approach. And the final one is the emergence of many new medications.
Mhm. So, yes, I mean, I think that's right, that we used to believe that endometriosis was purely a cause for pain and infertility, but we now know there are many, many more associations. What can you tell us about that?
Okay, so actually, previously, endometriosis was thought to be the cause of pain and infertility with nothing more. However, new findings revised the concept. Many epidemiological studies revealed that endometriosis is associated with many diseases, including cancers, autoimmune diseases, cardiovascular diseases, metabolic diseases, mental disorders, and chronic pain syndromes. An important point is the association is becoming more and more clear. However, the cause-effect relationship is still very vague. And the exception is in cancer, so especially in clear cell carcinoma. So in the last few in the recent years, it's very clear that endometriotic lesion has genetic mutations in proto-oncogenes, and which explain why endometriosis develops ovarian cancer, especially clear cell carcinoma. But in contrast, the relationship between endometriosis and other disease is so vague. So why? Maybe it's because endometriosis induces inflammation, which contributes to chronic systemic inflammation. Cardiovascular diseases and some autoimmune diseases may be their consequences. And what's more, autoimmune diseases may also be influenced by immune dysfunction and hormonal disturbance, which is often observed and in endometriosis patients. Okay, so given the findings, what effects does the treatment for endometriosis have on the association? Does it decrease the risk? I don't have the answer at the moment. Future research is necessary. Okay, so this is the big picture.
Mm, mm.
Okay,
And
and you understand?
yeah, and I mean, has this surprised you, the emergence of all these associations in endometriosis, or w should we have expected this all along?
Okay, so epidemiological studies revealed these associations, and some of them are very surprising, and some of them are intuitively reasonable.
Mm,
But more things I have to do is about obstetrical outcomes. And in addition to infertility, endometriosis has been revealed to be associated with obstetrical problems such as placenta previa, placenta accreta spectrum disorder, preeclampsia, and preterm prom. And we further investigated the association and found that severe endometriosis, let's say stage 4 endometriosis, had a significant association with placenta previa and preterm birth, but stage 1, 2, 3 did not have such association. And
mm,
others pointed out the same trends. So the reason is currently unknown, not yet known. And presumably inflammation, anatomical distortion,
mm,
and abnormal contraction of the uterus, which are found in women with endometriosis, are related.
mm,
And maybe you expect that surgical treatment would remove the adverse effect, but that's not true. There are several papers showing that surgery for endometriosis before pregnancy instead seems to increase the risk of placenta previa. So what should we do at the moment? I think the best way to go is to prevent the development of endometriosis by treating it as early as possible.
mm. Well, certainly a noble goal, early intervention following an early diagnosis. So, what about the shift to an early diagnosis? Um, can you tell us a little bit more about that and what that can do for those for the sufferer of endometriosis at an early stage?
Okay, thank you for asking a great question. So previously, as you know, laparoscopy was the gold standard for diagnosis. Of course, still, that is the case in certain circumstances. In addition, surgery, which is mainly done with laparoscopy, has had a significant role in the treatment of endometriosis. However, laparoscopy is less used for the diagnosis as well as the treatment of endometriosis. Clinical diagnosis is often preferred. One of the reasons is that there's no evidence that laparoscopic diagnosis is superior to clinical diagnosis in the management of endometriosis. And the improvement of imaging seems to support the trend. Ultrasound machines, MR machines, are superb these days, having a much better performance compared to the previous models.
Mm,
But having said that, so I want to warn you one caveat. A negative imaging result does not rule out endometriosis.
mm,
Okay? So you can make a clinical diagnosis from signs and symptoms and vaginal examination. Maybe you understand this very easily.
mm,
But what should we do when vaginal examination hardly shows positive findings, while there's a strong suspicion of endometriosis by signs and symptoms. Okay, in such a case, try empirical medical treatment. If it is successful, continue the treatment. If it fails, diagnostic laparoscopy is an option. Of course, you have to rule out other causes which may cause endometriosis-like symptoms and signs. Okay, so, and in terms of the treatment, laparoscopy is now less popular because it's known that endometriosis very often recurs after surgery. And to prevent this, it's known that continuous medical treatment is needed. So, why don't you treat endometriosis patients with medications as a primary option after clinical diagnosis? Okay? So in many circumstances, you can start medical treatment earlier with a clinical diagnosis than with a laparoscopic diagnosis. And this is in line with the concept that early diagnosis plus early intervention is vital for prevention of the development of endometriosis.
So there has been a big move towards continual medical therapy as first of all, a way of preventing progression of endometriosis, but also of preventing it coming back after surgery. And I think anyone who is familiar with the endometriosis literature will realize that you, Yutaka, have been absolutely pivotal in trialing and testing innovative medical treatments. So, I think that has to be regarded as one of your very, very strong suits. You are an absolute or the absolute world leader in doing so. What can you tell us about new medications that are now available for endometriosis?
Okay, so there are several points you should bear in mind. So the first one, for a long time, COC, combined oral contraceptives, have been empirically used for the treatment of endometriosis, but they have no label or no authority-approved indication for endometriosis. And why they used? Because the use is mainly based on guidelines. However, in the last decade or two, I have joined several RCTs for the medication to be approved by the authority. And those RCTs have clearly shown that COCs reduce endometriosis-associated pain as well as the size of endometrioma compared to the controls. And they also improved quality of life of women with endometriosis. This is the first point. And the second point, and apart from COCs, dienogest is now widely used for the treatment of endometriosis. And according to the RCT comparing dienogest and GnRH agonist, dienogest has substantially the same effect in pain relief, but has fewer adverse effects. But there's still a concern that dienogest may reduce the bone mineral density since it slightly reduces serum estrogen levels. The extent of impact of dienogest on BMD is far less than that of GnRH agonist and antagonist, but it could be still a problem if the patient wants to use it for many, many years. To solve this problem, we've developed a new strategy. We used dienogest at 1 milligram a day instead of the original 2 milligram a day. We demonstrated by RCT that dienogest 1 milligram a day was very effective in alleviating the menstrual pain associated with endometriosis, as well as with adenomyosis and with fibroids. And we found that 1 milligram a day was almost as effective as 2 milligram a day for alleviating dysmenorrhea. And in terms of adverse effects, I want to insist that 1 milligram a day GnRH is different from 2 milligram a day GnRH in that 1 milligram a day does not decrease serum estradiol levels, while 2 milligram a day slightly decreases the estradiol levels. So in my practice, I sometimes start from 2 milligram a day and change to 1 milligram a day for a long-term treatment of endometriosis. This is the second point. And the third point, this is related to COCs. We should be aware that our recent RCT demonstrated a new COC, which contains estetrol, suppressed endometriosis-associated pain. Why this is so important? So estetrol is a body-identical estrogen and has a less adverse effect on the coagulation system. This advantage leads to the expectation that COC containing estetrol has a lower risk of thromboembolism. This is the third point. And the final point, maybe two more, and this is the advent of GnRH antagonist. Okay, so an oral, so you can take by orally, oral GnRH antagonist suppresses endometriosis-associated pain as a GnRH agonist injection does. And now we have 3 oral GnRH antagonists on market, namely Velugolix, Elagolix, and Linzagolix. And compared to GnRH agonists, which are usually administered by injection, oral GnRH antagonists have several advantages. First and foremost, the antagonist suppresses serum estradiol levels from the beginning, while the agonists transiently increase serum estradiol levels for a week or 2 and then suppresses the level. So the expected effects of the medication appears much sooner in the antagonists than in the agonists. And secondly, oral GnRH antagonists have good adjustability. The half-life is very short, say within a day or 2, so they quickly disappear from the blood. If a patient has any adverse effects caused by low estrogen levels, such as menopausal symptoms, they will recover very soon once the patient stops taking the medication. And this is a clear contrast to GnRH agonist injection, which induces hypoestrogenic status for over a month. And another advantage of oral GnRH antagonist is that a patient does not have to visit every month, which is necessary for GnRH agonist injection. So you can prescribe 3-month doses, okay? So they don't have to come again after 3 months. They have to come again after 3 months in such a case. And despite these advantages, GnRH antagonists generally cannot be used for longer than 6 months before they induce bone loss. To overcome the adverse effects, GnRH antagonist-addback treatment has recently been developed. This is very new, but the concept itself was very old. The concept of the add-back treatment has once introduced in 1990s with GnRH agonist. Okay, so maybe this is a kind of a revival. And the add-back treatment increases serum estrogen levels to some extent and inhibits bone loss, while it does not impair the curative effect of endometriosis. Okay, so the combination tablet containing relugolix plus ethinylestradiol and norethistral is approved for endometriosis-associated pain in some countries. And other GnRH antagonists can also be used with hormonal medications for add-back treatment. Since GnRH antagonist add-back treatment does not decrease bone mineral density, it can be used for a long time. Okay, so very, very good medication. However, so in my country, in Japan, add-back treatment has not yet approved. So what I do in my practice is I use GnRH antagonist for a month or two and switch to dienogest or COCs when a patient has tremendous severe pain at the beginning. And more important point is that it's generally said that COC or dienogest is a first line and GnRH antagonist is a second line, but I think the flexible use of the medication is beneficial for an individual patient. So you should discuss with the patient what kind of medication you should use.
I'm loving hearing about your very flexible use of the available medications, because that's always felt a little strange to me that we declare that the combined pill and progestins are first line and then the others are next line, whereas they may well have advantages that they could be first line and only line and long term. For example, the relugolix combination therapy, there are data emerging now that probably long-term use is reasonably safe. I'm very interested to hear about and it seems to be only in Japan, use of dienogest 1 milligram. So is it true that this is only available in Japan?
Maybe so. So I don't know any other countries which approve 1 milligram a day officially.
Yes, interesting. And um, is the combined pill with estetrol or estetrol, as some people call it? It's E4, isn't it? And that is very much the bioidentical estrogen. Is this also more widely available than just in your setting, Yutaka, as far as you know?
Yes, in European countries, Western countries.
Mm.
So the hormonal tablet containing estetrol is used as a medication for menopausal symptoms.
Mm. Look, this has been a most amazing look at the advances and the new understandings that we've had within endometriosis in this last decade. It's clear to me that there has been a vast change in our understanding of endometriosis. And look, on behalf of Aspire, I just want to thank you for sharing your wisdom and your insights, Yutaka. Thank you very much indeed. And I'd like to thank Aspire for giving us the opportunity to share your wisdom and your knowledge.
Thank you,
Thank
Neil.
you.
So thank you, Neil. So it's a great privilege for me having had this talk here. Thank you very much.